Welcome back to Mobility Agility Chiropractic Performance. I'm excited to be here tonight. I'm Melissa McDonald, or Dr. Mac, here in Edina, Minnesota. Tonight we're going to be talking all about the knee. Whether you're recovering from an injury, such as a ACL, a meniscus tear, or a sprain that you sustained through activity, or maybe you're just getting to the point in your New You being active that you're starting to feel sore and have knee pain with the increased activity you're doing, or perhaps you just have knee pain that's preventing you from being active. This is what we're going to talk about tonight. So if you're watching live, please comment #live. If you are watching this on replay, #replay. We will answer questions throughout our live feed. I'm going to make sure that I have our questions visible for me so that I can see them. Just give me a moment and we will get going. There we are. All right. Hey, Tim. Hi, Denise. Hey, Ashley, welcome to our live feed tonight. If you guys have any questions, please feel free to go ahead and answer below. And we're going to get right into the knee. So, what is the knee? Let's do a quick understanding of the anatomy, because there are some big ligaments that have a tendency to get injured and cause problems. So right here, we have the knee. The kneecap or patella is what attaches and helps hold the knee together, and then we have our internal ligaments. This one here in the front is our big ACL, and it is the one that most commonly tears and ruptures when there is a collision or non-collision type accident where your knee shifts internally and snaps back and causes significant pain. Most common in female athletes compared to men. It has to do both with the shape of our hips, the size of our joints, and our hormones to why that is the case. Behind the ACL is our PCL. It's not as common to injure, but when it happens, it's usually a significant trauma, such as a car accident or a significant hit to the front of the lower bone, the tibia, that actually shears it off the femur, which is the bigger bone at the top. And then we have on the outside our medial and lateral cruciate ligaments. And those commonly, the medial cruciate ligament, or the MCL, more commonly gets injured with our ACL. So I really wanted to just kind of show the gross anatomy. Then the bottom bone has our menisci on it, or our meniscus, both the inside meniscus or medial meniscus and our lateral meniscus. And those are probably the two things that can cause us the most pain as we break down our knee, and as it degenerates, those are some of the things that can catch and fray and cause problems. And when we tear a ligament, we can also have issues where they catch and click and cause pain. And for me, that's what I have. My left knee has a torn meniscus in it, and it causes problems. It doesn't necessarily prevent me from doing anything anymore. A couple years ago, it did lock, and I was not able to straighten my leg or bend it past 45 degrees. It just kind of stayed in that position, and it left me on crutches for about 3 weeks. And I was starting to think that I needed to go see an orthopedic surgeon to contemplate getting it straightened out. I went to a chiropractor, had my knee adjusted, because that's my first place I go. Didn't honestly help that much for that in particular. So I ended up going to an acupuncturist who, at the time, I had been icing my knee every hour, on the hour, for 20 minutes at a time, just to manage the pain. They yelled at me, said, "Stop icing. You need to utilize heat. That's going to make the difference with your knee." And I then went and they needled into my knee joint. Am I going to tell you that it was comfortable? Absolutely not. It was probably one of the most painful experiences I have been through, but I walked in on crutches and I walked out on my own weight. Since then, I really haven't had any issues, and I've just made sure to maintain an active lifestyle of weightlifting and exercising and just keeping active to keep my joints healthy. So I actually have a knee model here tonight to help Coach Mac from the Minnesota Venom. He's going to hop up on the table so we can look at the knee, not only from what we looked at the internal side, but actually from the external side. So when we're looking at this, we have our kneecap, which is free floating here. We have our tibia down here, our femur here, and our fibia out here on the outside. These four bones compose our knee joint, and any one of them that's not moving ideally can cause pain, which is where a chiropractor can come in and adjust them. Probably the most common place we have pain is kind of out here on this outside of our leg or lateral side can be an issue, and that can be where our iliotibial band or IT band comes down and attaches, and this can kind of become common with our runner's knee. But that really could be our fibia down here not actually moving with the joint, because it comes down all the way to the ankle and it needs to be able to rock back and forth. And when it's not able to, that can cause pain and difficulty. The other place I commonly see pain is our kneecap. And this is because we can have overdeveloped quad muscles. And you can kind of see that here. We have a little bit of a larger vastus lateralis, or a lateral quad, and a little bit lesser developed medial quad here. And that can cause some patella tracking issues and knee pain with repetitive motion. So we really want to make sure that we are addressing that issue there, because it can feel like an internal pain. So I'm going to have you go ahead and lay down, and we're going to look at what are some simple exercises. I alluded to this yesterday with my post, so if anybody saw that, these aren't going to be too excitingly new, but what they are going to do is I'm going to break down how to actually do them effectively. So when we're looking at a quad set, what we're trying to do is engage our quads, work on extension of the knee, because that's what we lose when we have injury and when we have any pain. We don't like to extend our knee. So I'm going to go ahead and have you do a quad set for me, Andrew. Squeeze that quad, engage it, and we're just extending the knee, engaging our quad. And this is also contracting on our patella. So if we have someone that's having issues with patella tracking, we can apply tape and put an emphasis on a direction that we want them to better contract. If we're having a muscular imbalance where one side is activating more, we can help by simply just adding a perturbation or just an activation or a cue. Hey, I want you to work here, to help create more activation. Now, this is all non-weight bearing, which is super nice for if you're having pain with any movement. This takes that out of it. The other thing I want you to do now is a straight leg raise. This just engages the quads a little more, so go ahead and lift your leg up. This just hits that quad nice, forces a full extension of the leg, and then he can go back down. And we can do sets of 5. And again, patellar tracking, muscle engagement, extension, the things that we lose the fastest with injury. Now, if we're having range of motion difficulties, so you're having pain at certain points in, let's say, a squat or a lunge, we can then work and see where those pain points are pain-free. So if you bend your leg up and bring your heel towards your glute, there we go, and then straighten it back out, we can actually slide the foot back and forth in a gliding motion to work through ranges of motion while non-weight bearing. This is a really nice way to Work on this without increasing pain or symptoms. But once you're ready, let's go ahead and get up and start working on some squats and lunges, and what areas of the squat and lunge you need to focus on to prevent further injury. So as we're working, a lot of times when you're dealing with the being active, there are aspects that you're missing. So I'm going to go ahead and have you turn and face the mirror and go ahead and squat down and then hold at the bottom. So as he gets down to the bottom of his squat, we're looking at where his knee is to his toes and if he's in front of them. So I'm going to move my mic a little bit so we can actually see where he's at. So go ahead and go back down. So as he gets down, you can see that his knees stay behind his toes. This helps prevent any pressure on his knee and reduces the tension. Go ahead and stand up. Now, if he actually pushes his knees past his toes, which I know is a hard thing to do, this is where you have the most amount of pressure and the potential risk for pain and injury. But a lot of times we do this because we don't feel comfortable actually sitting back and having our weight sit back into our heels. Go ahead and come up. Now, this becomes important when we're looking at how things kind of move, how people move. When we're not comfortable with where our body is in space, we fight what's going on. The other thing that can cause issues is our lunge. So I'm going to have you face me, go ahead and lunge towards the camera and give me a good lunge. So what we're looking for on a lunge is a nice straight knee again behind the toes, and our knee stays in line with the body. Go ahead and come up. I can't wear him out too much. He has hockey tonight, and I don't want to completely burn out his quads. Go ahead and step back on the back leg. Give me a valgus. So a valgus knee is when you let your knee come in. We don't want to see that. That's a lot of pressure. And then come up. Same thing with squats. We don't want to see your knees come in on a squat. Those are a lot of common things that can cause pressure and injury. So when you're working out, we want to make sure that you're using good form. Just going to grab that. We want to make sure that you're using good form. We want to make sure that you have mirrors, you have appropriate equipment, you have appropriate footwear to keep yourself safe. Because ultimately, when we're working out, we're trying to be healthy and we have to make sure that we don't injure ourselves further. So keep your knees behind your toes. Keep your knees in line with your feet, and you should be just fine. And if you're having pain, using the quad sets, straight leg raises, and heel sliders can help you take control. When I'm having a bad knee day, I use those as my warm-up. I use those to start getting my legs warmed up and ready to do bigger movements. Then I start with quarter squats. Then I go to full squats. Then I start loading them. It's all about slowly and incrementally increasing your ability to hold and maintain the load on the joint to prevent pain. The other thing is a common misconception with knee pain is that running will cause knee degeneration, and that's just not true. When we have the biggest risk for knee pain and knee degeneration is when we stop using our knee, when we stop moving. Sitting still is the death of our joints, which is a pain since we have to mainly sit all day at our jobs, or we have to stand all day at our jobs, and that's not ideal. We need to be moving. The joint movement actually lubricates the joints, keeps the menisci and the space healthy. That's why a lot of times with long distance runners, you just don't see the degeneration that you see with someone that has been in a sedentary job. Now, there are going to be times that conservative care is not going to be able to manage your knee pain. So if you're doing these exercises and you're still not getting the results you want, you need to make sure that you follow up with a chiropractor or with a physical therapist or with your primary doctor to find out truly what's wrong. That doesn't necessarily mean you need an x-ray at that time, because what you are seeing on the x-ray is not indicative of the pain. You can have a horrifically bone-on-bone knee that's not painful because the person has kept moving and not had any issues. And you can have someone with minor degeneration that's in significant pain. But if you don't progress through co-manage, so if you go into a chiropractor, you go into a physical therapist, they get you into a treatment program, you're diligent with your exercises, you're involved with your health, and you move forward, then that's when if that doesn't work, then you need imaging. And based off that, there are times that you have to see an orthopedic surgeon. Full disclosure, it doesn't always work conservatively. I would like to say that I have fixed every knee that came in and got it back with no issues, but especially with like an acute trauma such as an ACL, it may benefit the person if they're not able to stabilize. Granted, research has been showing that it may not be necessary, and 10 years after an ACL reconstruction, they're actually having more degeneration compared to a non-restructured knee. So that's new. It's still kind of very green in the research that we're looking into it. But even with my own family, my mom has bad knees. I have bad knees. I don't think my sister does. My dad has phenomenal knees because he runs 6 miles a day. But my mom ended up having to have 2 total knees. And there was nothing I could do to prevent that. I tried my hardest, but it just was how it went down. So it's important to start with the least invasive method, which is simply stay active, be active, and use your joints. Keep them mobile. So does anybody have any questions with what I kind of quickly presented with you this evening? I know we kind of burned through what a knee is on the anatomy. We looked at some basic non-weight bearing exercises because I want to make sure that I cover every aspect of what a knee, how to make modifications. If you're struggling with your squats, to actually sit back, trying a box squat. And that's simply where you have a chair or you have a box behind you and you sit back and then you stand up with your squat. That can help you get better control of your weight being dispersed equally on your heels and toes. To see if you're pushing your knees past your toes, you can use a foam roller and set the foam roller on its end in front of your toes. So as you squat down, if your knees go in front, it knocks it over. Some people use a wall. I find that I fall over when I do that. So I use a foam roller to kind of track where things are and how things, positioning wise. Try to always use a mirror, or if you don't have access to one, videotape yourself so you can see how you're moving and what's going on. And we have a question. What is the best cardio for people with knee pain? I fully admit that cardio is not one of my strong suits. I'm a lift the weights faster type of person when it comes to cardio. But whatever cardio doesn't hurt. If running hurts, try elliptical. If elliptical hurts, try biking. If that hurts, try rowing. And ultimately, if none of those work, going anti-gravity by swimming will definitely get you your cardio exercise without having any knee involvement. But it really is scaling. So as you start to run or whatever cardio you're doing, start small and gauge it up. That way your joints actually adjust to the load. When we go out there and we're like, oh, I'm going to go run a mile. For me, never happens. But I'm going to go out and run a mile. and then we hurt afterwards, and we haven't ever done that in many, many months, that causes a significant issue. So what you really, really need to do is scale it. Start with a quarter mile and then walk. Go to a half mile and then walk, and slowly just incrementally increase the load so your joints can get ready for it. I have issues with this because when I get to the gym, when it comes to lifting, I like to go right back to the weight I was at the last time I went to the gym and lifted heavy. And between heavy sessions, it can be a month or two, which is not the best, but it's kind of how it's been. I've been doing more yoga recently, and that is the worst thing I can do for my knees. If I slowly and incrementally load the weight, so dropping down to 135 pounds and then working up back into the 200s, my knees handle it better. When I jump to the higher weights, my knees scream and become very painful and force me into using a wrap or a brace to support them, which when I'm not doing any max loading is not ideal. We want to avoid using braces and assists unless we're doing max repetitions so that we can actually work the joints and work the muscles, because loading of them is what really builds up the integrity of the ligaments to reduce the risk of injury. Any other questions for knees from anyone that is watching? I see we have 6 people still logged in. I think I saw Liz and Lance and Melissa and Paul and Rachel. It is wonderful for y'all to have joined this evening. If you do have any questions after this video is done, please go ahead and comment below. Just comment #replay. I always respond and get you the answers you need or get you the information you need to someone. Ooh, we have some more questions. As far as shoes for lifting or cardio, is it better to have a harder shoe to support or a shoe with more buoyancy? So there is not one shoe that is perfect for both activities. And there's not one shoe. So there are runners that are running on the zero shoes where they're completely flat, nothing to them, and they love them. There are other people who run with the really thick cushions and they love them. It really is dependent upon the person. When it comes to lifting, I find a firmer, flatter shoe to be a little bit more comfortable for allowing your feet to spread to support the weight. So definitely with running, you want to make sure your feet can securely spread out on the ground. I even sometimes when I'm in a gym that allows it, lift barefoot. It's just a little more comfortable for me. I know Converse, those flat shoes, or even just the lifted shoes with the lifting shoes with lifted heels. Really great options, but they're horrible to run in and just don't move the way your foot moves while running. So for lifting and running, you really need 2 separate pairs of shoes to best address the needs of what activity you're doing. All right. We have another question. So there's a question concerning did I see the knee injury from Connor McDavid not having surgery and only doing rehab by a chiro? So for those who don't know, Connor McDavid is a professional hockey player. He is one of the best in the league currently, and really ultimately is probably going to be one of the best hockey players of all time. Not that I'm a fan of the Oilers or anything. But at the end of last season, he sustained a pretty significant knee injury where he tore his PCL, meniscus, and sustained a fracture of his tibia. And all the doctors he saw up in Canada had recommended that he undergo surgery. Well, as one of the fastest skaters on the ice and the fastest skater with puck handling skills that he has, he was scared that that would affect his gameplay. So he sought a second opinion and actually Sought one from a chiropractor in, I believe, the Los Angeles area, who recommended, you know what, let's do conservative care and an intense rehab program and see where we can get you back to. Because unlike ACLs of the knee, which are very common, I know when I worked with the Minnesota Vixen, they sustained an average of 4 to 6 ACLs a season, which female knees in contact sports, not a good deal. The PCL is not as common of a surgery, so they just couldn't give an outcome of how well he would do afterwards. He did extensive off-ice training and rehab with the chiropractor, and when he came back this year, I honestly had forgotten he was injured. And I believe his points on ice really dictate that he has not been affected and has been doing quite well. So right there, that shows a significant severe injury, and one of the highest level hockey players ever still is performing at a phenomenal level without having had to have surgery. That was kind of cool. All right, we have another question. Can you speak about valgus deformities after total knee surgery, and is it correctable? So valgus deformity is, again, where the knees actually go in, and it's colloquially known as knock knees. A lot of times when this is happening, it may not actually be the knee that's the issue. When it comes to orthopedic surgeons, they do a due diligent job of measuring and ensuring that the knees are aligned appropriately. It honestly could be an issue coming from either the hips or the feet. And if your arches in your feet are actually flattening out, this can cause your knees to roll in, because it causes the tibia to actually turn in and cause the knees to knock. Valgus deformity of the knees almost never is actually a knee deformity, which is silly unless it is congenital. So if you're born knock-kneed, then it can be an issue. For correcting that, I utilize a lot of foot strengthening exercises if it's a foot issue. So working on the intrinsic muscles of the feet and strengthening them with short foot exercises. I like to use a gadget called a Toe Pro to help really get the feet engaged and strengthen the muscles so that you have integrity there. I'm not a big orthotics person. I honestly think that can, in the long run, make the problem a little bit worse if it is because of foot weakness. If you have a deformity of your foot that requires an orthotic, that is a different scenario. But if it's just your feet not being strong enough, then an orthotic can honestly make it worse. If it's a hip issue, that takes a little bit more very specific exercises depending upon what's going on with your hips. So that would need a chiro or physical therapy assessment, to be completely honest. Any other questions this evening? Again, if you're watching live, please go ahead and hashtag live. If you're watching this on replay, hashtag replay. If you have any further questions, even after logging off, I will get in there and answer them. And if you have a topic for next week, for next week, please post in the comments what the topic you are interested in. Last week we did nerve flossing and carpal tunnel syndrome. This week, knee pain. I base my topics off of what questions I'm being asked both here in practice and online, because I want these lives to be as specifically geared to your interest so that you can get the help you need. Well, I'm not seeing any other questions this evening. I have seen some other people. Oh, we got one more. I have seen some other people log on. Welcome, Ashley, Lacey, Austin, and Ace. Yes, Rachel, hashtag crack addict. Bless you. Another question. Can you touch a little bit more on why females have more knee injuries? So this is actually what I did my fellowship on, was all about understanding the injury patterns of females and how we can prevent and protect them from these issues. So there are kind of 6 key factors when dealing with knee injuries. One of them is muscle and joint size. So females have smaller joint surfaces compared to men because we are smaller framed generally, comparatively. And this is really speaking to anyone that at birth was sexed female at birth. And then on top of that, our hips, our pelvis is actually shaped wider so that it provides an appropriate birthing canal. And this changes the angle of our femurs to our knees. This is called a QL angle. Now, the research is intermittent on whether that actually is a true factor, but when you combine everything, that's when it becomes an issue. Then we have joint size, muscle size, QL angle, hormones. So the cycling of a female on hormones from the estrogen to progesterone phase, actually at the middle at day 14 of the cycle, when ovulation occurs, we actually release relaxin, a hormone that is more commonly associated with pregnancy, and it loosens our ligaments. So our ligaments actually stretch more, and that causes our joints to be able to be moved at a greater amount. Increased ligament laxity is 5, and I might only be able to come up with 5 right now because I am blanking. So let's go with 5, not 6 facts, 5 facts on why women are more likely to sustain a knee injury. Most common places that ACLs are torn for females are going to be basketball courts and soccer fields. The only place within the sport realm that the ACL injury is equal between men and women is downhill skiing. So if you're a downhill skier, please be extra careful and make sure your knees are appropriately trained and ready for that load. I'd hate to see you sustain a significant injury. And I see we also have Amber joined in and Megan joined in. So I'm so happy that everybody was able to tune in tonight. Again, if you have any further questions, please go ahead and type the question below. If I don't get it tonight, I will respond to it later. If you are watching this on replay, #replay. If you're watching this live, #live. Thank you for joining me this evening. I hope you have a great night. Please comment with any topics that you would like to be covered in a future live. Other than that, I'm going to go. Have a good evening. And remember, here at Mobility Agility Chiropractic Performance, we are always trying to get you better faster, keep you better longer, because no one has time to be sidelined. To keep up to date with future content, please click subscribe. Additional information is found in the description of this video.
All information, content, and material of this video is for information purposes only and are not intended to serve as a substitute for the consultation, diagnosis, and/or medical treatment of a qualified physician or healthcare provider.